how can we really know if one treatment is actually better than another? Especially in orthopedics, it's not just guesswork, is it?
No, absolutely not. It relies on, well, a really meticulous process of gathering solid evidence.
And that's what we're diving into today, isn't it? The foundations, the methods behind clinical orthopedic research.
Precisely how we actually build that evidence base.
We've got a stack of source material here, research papers, notes, and we're going to pull out the really crucial bits about how studies are designed, run, and importantly, how you can understand them.
Which is key for anyone in the field, really, whether you're doing the research or using it to make clinical decisions.
And I'm thrilled we have Professor Mo Imam with us to guide us through all this complexity. Welcome.
Thank you. It's a pleasure. Thinking about how we know what we know. It's fundamental, isn't it? It gives you real insight into the evidence you're using every day.
It really does. It's like knowing how the engine works. So over this deep dive, we'll cover the ethics, the absolute must-dos,
Non-negotiable.
and then the practicalities of study design. Things like sample size, blinding, how do we measure what actually matters to patients?
Yes, outcome measures are critical.
Yeah.
And then understanding the data, the statistics, the different study types.
Right. And we'll touch on the bigger picture too. Things like multi-center trials, registries.
Indeed. And even the economics of healthcare, which is becoming increasingly
Right.
important. The whole ecosystem, really.
Fantastic. A Procter deep dive. So let's start with a concept that's everywhere now. Evidence-based medicine. EBM. What does it actually mean? Where did it come from?
Okay, EBM. Well, at its heart, it's about using the best current evidence conscientiously, explicitly, really thoughtfully when making decisions about individual patients. That definition from Gordon Guyatt and the McMaster Group back in '91 really crystallized it.
But it's not just about the research papers, is it?
No, that's a common misconception. It's a three-legged stool, really. It's integrating that best external evidence with your own clinical expertise and, crucially, with the patient's values and preferences. All three are vital.
That makes sense. A balance.
Exactly. And while that definition is relatively recent, maybe late 20th century, the idea of looking systematically at outcomes.
Well, that goes back much further. The source material mentions Dr. Ernest Codman.
Ah, yes, Codman. His story is quite something, isn't it? His end results idea.
It really is. He was proposing, back in the early 1900s, that doctors should follow every patient to see the final outcome.
Every single one.
Every one. And if the result wasn't good, they needed to investigate why, systematically tracking failures to learn from them.
Sounds completely logical to us now. Why was that so radical then?
Well, it flew in the face of the established practice, which was much more based on authority and tradition, perhaps anecdote, scrutinizing every failure, publicly almost. It wasn't the done thing.
So it caused friction.
Significant friction. The sources mention it cost him his job at Massachusetts General Hospital.
Wow.
But his insistence on patient outcomes as the ultimate measure, well, that's now seen as a cornerstone, a really foundational step towards the empirical medicine we practice today. A difficult path for him, but crucial for progress. So we have Codman's early ideas, then the formal EBM definition. How did it become so widespread?
It was a confluence of factors, really. You had the intellectual framework from Guyatt and others, but what really powered its almost explosive integration was the simultaneous revolution in information technology.
Ah, the rise of computers and databases.
Exactly. Suddenly, you could search huge amounts of literature,
Yeah.
manage large data sets, synthesize evidence in ways that were just impossible before. The technology made the EBM concept practically achievable on a grand scale.
So the tech unlocked the potential of the idea.
Precisely. It meant a scientific, data-driven approach could genuinely complement and sometimes challenge traditional ways of thinking in clinical practice.
But before we even think about generating that data, there's the ethical foundation. It's mentioned as absolutely non-negotiable. Why is protecting research participants so critical, especially in orthopedics?
It's paramount. Fundamentally, clinical research involves asking individuals to potentially accept some risk, whether physical, psychological, or to their privacy, for the benefit of others, for future patients. The ethical framework is there to ensure the rights, dignity, and well-being of those participants always come first.
Oh,
Always.
we're guests of our patients, as you said.
Absolutely.
And overseeing this are institutional review boards, IRBs, or ethics committees.
Yes, IRBs or IECs, depending on where you are, their job is essentially to be the advocates for the research participants. They scrutinize the research plan, the protocol,
To ensure.
to ensure risks are minimized and justified by potential benefits, that patient selection is fair, and crucially, that the informed consent process is robust and truly allows for an informed choice. Their mandate, particularly in the U.S., comes from principles like those in the Belmont Report, formalized in regulations like the Common Rule. They're gatekeepers, ensuring research is conducted ethically.
Does every single study need IRB approval then? Or are there exceptions?
Not absolutely everything. The sources point out that things like internal quality improvement projects, perhaps some types of case reports focusing on just one or two patients, these might not always meet the formal definition of research designed to create generalizable knowledge.
So they might not need formal review.
They might not. But, and this is a critical piece of advice, if there is any doubt at all, you absolutely must consult your IRB or ethics committee before you start anything. It protects everyone involved. Better to ask than to make assumptions.
Sound advice. And a cornerstone of that protection is informed consent. It's called a fundamental pillar. What does informed really mean here?
It's about genuine understanding and voluntary choice. It's not just giving someone a leaflet. You have to ensure the potential participant truly grasps the study's purpose, what procedures are involved, the potential risks and benefits, what alternatives exist,
And critically.
that taking part is entirely voluntary, and they can withdraw at any point without any penalty, without affecting their normal care. They need to be able to explain it back to you in a way. It's an ongoing conversation, not just a signature on a form.
That sounds like it could be tricky, especially with certain patient groups.
It absolutely can be.
Huh.
The sources highlight the need for extra care with vulnerable populations, children, people with cognitive impairments, perhaps even situations where there's a power imbalance, like if the researcher is also the treating clinician.
So how do you manage that?
Well, for those lacking capacity, you need proxy consent from a legal representative. But even then, the ethical obligation is to respect the individual's potential views and best interests as much as possible. It requires real sensitivity and ensuring the process isn't coercive in any way.
Respecting autonomy seems key. Now, once someone's in a study, what about their data? Protecting confidentiality.
Hugely important. Data protection regulations like EPA in the US or GDPR in Europe are very strict. In practice, it means using study codes instead of names on data forms, keeping records secure, ensuring data is accurate and legible.
And the consequences if things go wrong?
They can be severe, as the source material makes clear. Data breaches can lead to reputational damage, research being halted, significant fines, and potentially even legal action against researchers. Trust is incredibly hard to regain once lost.
A heavy responsibility. Beyond patient data, there's the issue of conflicts of interest, COI. How is that defined in a research context?
The Institute of Medicine definition is widely used. It's basically when circumstances create a risk that a researcher's professional judgment about a primary interest like patient welfare or research integrity might be unduly influenced by a secondary interest.
Like financial gain.
That's the most common one, yes. Especially with industry funding. You often have the researcher, their institution, and the company providing funding. Their interests might not always align perfectly. An ethical issue arises if financial ties could potentially bias how the research is conducted, analyzed, or reported.
And industry funding is pretty significant, isn't it?
It is. The source notes figures like 71% of R&D funding in the U.S. coming from industry. And there's documented evidence, quite a lot of it, actually showing that industry-sponsored trials are statistically more likely to report results favorable to the sponsor's product.
That doesn't necessarily mean the research is flawed, though.
Not necessarily, no, but it highlights a potential for bias that absolutely must be managed transparently.
How do researchers navigate that? Are there guidelines?
Yes, professional bodies like the AAOS provide guidance. For example, suggesting researchers shouldn't trade stock in the funding company during the project. Or, if a surgeon has designed an implant and receives royalties, research on that specific implant should ideally be done by someone completely independent.
What about consulting fees?
Legitimate consulting is fine, provided the compensation is fair market value for the work done, and, crucially, it's fully disclosed. Transparency is key.
Disclosure and management, not necessarily prohibition. Are there system-level responses to COI concerns?
Yes. A major one is mandatory clinical trial registration. Public databases like clinicaltrials.gov, ISRCTN or the WHO registries, they require researchers to outline their study design, their methods, their primary outcome measures before they start recruiting anyone.
How does registering beforehand help?
It locks the plan in publicly. It makes it much harder to engage in things like publication bias, where only positive results get published, or selective outcome reporting, where maybe you change your main outcome measure after you've seen the data because another one looks better.
So it increases transparency.
Hugely. It holds researchers accountable to their original plan. Many major journals, following the ICMJE guidelines, now won't even consider publishing a trial unless it was registered beforehand.
A powerful incentive for good practice.
Right, so ethical foundations are set. Let's move to designing the study itself. It all starts with a research question, doesn't it?
Absolutely. A clear, focused question is the starting point. It might come from clinical observation, spotting a gap in the literature, wanting to follow up on earlier work.
But how do you know if it's a good question, one worth pursuing?
There's a useful framework called the finer criteria. Is the question feasible? Can you actually do it? Interesting, will people care? Novel, does it add something new? Ethical, can it be done ethically? And relevant, does it matter to practice or policy?
Finer. That's neat. Feasible, interesting, novel, ethical, relevant.
Exactly. It helps you refine your initial idea into something concrete and justifiable.
Once you have that finer question, how do you structure it for a study plan?
The PICOT format is incredibly useful here, especially for clinical questions. Population, who are the patients? Intervention, what's being tested? Comparator, what's it being compared against? Outcome, what are you measuring? And time frame, over what period? PICOT, population, intervention, comparator, outcome, time frame.
Using PICOT clarifies exactly what the study is about. It makes communication much clearer.
So PICOT defines the question. Then comes the study protocol, the master plan.
Precisely. The protocol lays out everything in detail: the background, the objectives, the exact methods for recruitment, intervention, data collection, the statistical analysis plan, ethical considerations, timelines, everything. And the key point the source makes is this must be finalized before you recruit the first participant.
Why is that timing so critical?
It prevents people from changing the rules halfway through the game, essentially. If the methods or analysis plan aren't fixed beforehand, there's a risk, conscious or unconscious, of making changes based on early results, which can introduce bias. It ensures the study is conducted systematically as planned.
And a crucial part of that plan is sample size calculation, getting the numbers right.
Yes, vital for statistical power. Power is the study's ability to detect a true difference or effect if one actually exists.
And if the sample size is too small,
then the study is underpowered. You risk a type 2 error, a false negative. You might conclude there's no difference between treatments when, in reality, there is one, but your study just wasn't big enough to find it.
is that a common problem in orthopedics, being underpowered?
The source suggests it might be, yeah. Estimates suggest maybe up to half of orthopedic RCTs could be underpowered, which makes interpreting those negative trials, the ones finding no difference, really tricky.
Because you don't know if it's truly no difference or just miss.
Exactly. And remember, the power calculation itself is based on estimate assumptions about how big the effect will be and how much variability there is. If those assumptions are off, your actual power might be lower than planned.
So there's always some uncertainty. Do researchers build in a buffer?
Yes, it's pretty standard practice to inflate the calculated sample size by, say, 10 or 20%, just to account for people dropping out or maybe not recruiting quite as many as hoped. It's a pragmatic way to safeguard the power.
Makes sense. Alongside sample size, selecting the right patients is obviously key. And then in trials, randomization comes in.
Right. Appropriate patient selection defines who the results apply to. Randomization, in RCTs, is the best tool we have to minimize selection bias and confounding by assigning patients to groups purely by chance.
You hope to.
You hope to make the groups as similar as possible at the start, in terms of both things you know about, like age, severity, and things you don't. So any difference you see at the end is more likely due to the treatment itself, not baseline differences between the groups.
So randomization tackles bias head-on.
It's crucial for tackling selection bias and confounding in RCTs, yes. Bias can creep in anywhere, though: design, data collection, analysis. Selection bias is a big one, where the groups start off different in a systematic way. That's why historical controls are generally a bad idea comparing today's patients to yesterday's. Too many other things have changed.
Okay. Now, the sources make a point about allocation concealment being distinct from randomization. What's that about?
Ah, yes, a really important distinction. Randomization generates the random sequence who should go into which group. Allocation concealment is the practical step of shielding that sequence from the people enrolling participants. It ensures they don't know which group the next eligible patient will be assigned to before they decide to enroll them.
Why does that matter if the sequence is already random?
Because if the recruiter knows the next assignment, say the next one gets the new drug, they might consciously or subconsciously steer certain types of patients towards or away from that next slot. Maybe hold back a sicker patient if the good treatment is next, or rush to enroll someone if the placebo is next. It undermines the randomization.
So knowing the next step can reintroduce bias.
Exactly. And the source notes that older methods, like sealed envelopes, weren't foolproof. They could sometimes be predicted or tampered with, and studies using them poorly tend to overestimate treatment effects.
So what's the gold standard for allocation concealment now?
Centralized remote methods. Using a secure telephone service or an online system managed independently from the trial site. The person enrolling the patient contacts the central service after confirming eligibility, and only then are they told the group assignment. It completely removes the possibility of influencing the allocation.
That makes total sense. Keeping it separate keeps it clean. Another bias-reducing technique is blinding or masking. Who gets blinded?
Ideally, as many people involved as possible. Blinding prevents knowledge of the treatment allocation from influencing behavior or assessments. So you might blind the participants, subjects, the clinicians delivering the care, the people assessing outcomes, and the data analysts.
But in orthopedics, blinding the surgeon seems difficult.
Often impossible, yes. The surgeon usually knows exactly what procedure they performed. That's a major challenge in surgical trials.
So what can you do?
You focus on blinding everyone else. Patients can sometimes be blinded, perhaps with a sham procedure, though that raises its own ethical points. Outcome assessors can definitely be blinded, have someone not involved in the surgery or care collect the follow-up data, especially PROMs. You can mask scars on x-rays, for example.
And blinding the data analysts. You mentioned that earlier.
Yes, that's usually the easiest part. Just give them the data labeled Group A and Group B. Yet, the source points out it hasn't always been well reported in the past. It's a simple step to prevent bias in how the data is handled.
All these techniques, randomization, blinding, sham procedures, link back to an ethical principle. Clinical equipoise. What is that exactly?
Equipoise is the ethical justification for doing an RCT in the first place. It means there must be genuine uncertainty within the expert medical community about which treatment arm in the trial is actually better. It's not about the individual researcher's belief, but a state of collective uncertainty.
So if everyone already knows one treatment is superior,
then it's unethical to randomize. You shouldn't knowingly assign patients to what is believed to be an inferior treatment. Equipoise ensures randomization only happens when there's a real question about the best approach, making both options ethically acceptable within the trial context. It's particularly relevant when considering sham surgery. You need genuine uncertainty about the active procedure's benefit over the sham.
randomize only when you truly don't know. Okay, so we've designed the study carefully. Now we need to measure the results. The science of outcome measurement.
Absolutely critical. Outcome measurement is how we quantify the effect of the treatment. Is the patient better? How much better? It's essential for showing value, comparing care, seeing if evidence-based practice actually works. The WHO defines it as the change in health due to an intervention.
And how do we measure these outcomes? What are the main types?
Broadly, two categories. Objective or observer-reported outcome measures OROMs. These are things measured by a clinician or a device. Range of motion, strength, maybe using an instrument like the KT1000 for the knee laxity, functional tests like hop tests.
And the second type?
Subjective or patient-reported outcome measures, PROMs. These come directly from the patient, usually via questionnaires, about their pain, function, quality of life, symptoms, their perspective.
What are the limitations of the objective, OROMs?
Well, instrumented measures can be precise but also expensive or complex. Functional tests try to mimic real life but can be affected by patient effort or technique, sometimes making them less reliable. And crucially, an objective measure might not capture what the patient actually cares about. The KT1000 example is good. It measures forward-backward knee laxity well after ACL surgery, but not rotational stability, which might be the patient's main problem.
Which leads us to PROMs, patient-reported outcomes. They seem increasingly important.
Hugely important,
Yeah.
because they capture the patient's experience. How do they feel? How well can they function in daily life? It's about patient-centered care. What does treatment success look like from their point of view?
Are all PROMs the same?
No, there are different types. Generic ones, like the SF36 or SF12, measure overall health. They're good for comparing across different diseases or picking up broad effects, but they might not be very sensitive to changes in a specific joint problem.
So you also have specific ones.
Yes, condition-specific or region-specific PROMs. Things like the COAS for knees, the WOOS for shoulders, the Harris Hip Score. These are designed to be really sensitive to changes related to that specific condition. They're generally more responsive. The choice depends on what you're studying.
Choosing the right measure is crucial then. What makes a PROM or any outcome measure a good measure? What properties does it need?
3 key psychometric properties. First is reliability. Is the measure consistent? If you measure the same thing twice, do you get the same result, assuming nothing has changed? You need reliability to trust that any change you see is real, not just measurement noise.
Different kinds of reliability.
Yes, test or retest reliability, inter-rater between different assessors. Inter-rater, same assessor. Internal consistency, do items on a scale hang together? We quantify it with stats like ICC or Cronbach's alpha. For trials, you often want reliability above 0.9.
Okay. Reliability is consistency. What's next?
Validity. Does the measure actually measure what it claims to measure? Does your knee score truly reflect knee function? There's criterion validity, compared to a gold standard. Construct validity, does it behave as theory predicts? Discriminant validity, does it not correlate with unrelated things?
Reliability, validity, and the third.
Responsiveness. Can the measure detect change when it actually occurs, especially clinically meaningful change? A measure could be reliable and valid, but if it's too blunt to pick up improvements, it's not much use in a trial.
Right. Reliability, validity, responsiveness. So you've got your scores changing. How do you know if the change matters? Statistical significance isn't everything, you said.
Exactly. This is where MCID and MDC come in. Hugely important concepts.
NCID.
MCID is the minimally clinically important difference. It's the smallest change in score that patients actually perceive as beneficial or important. The smallest change that makes a real difference to them. MDC is the minimum detectable change, the smallest change that's statistically likely to be real, not just measurement error.
So MCID is about patient perception. MDC is about measurement precision.
You've got it. And ideally, for a change to be truly meaningful, it needs to be statistically significant and exceed the MCID. The source gives a great example. A trial finds a 4-point difference on the IKDC score, p.05, statistically significant. But if the MCID for the IKDC is known to be, say, 11.5 points, that 4-point difference is statistically real, but probably doesn't feel important to the patient.
That really clarifies the difference between statistical noise and meaningful improvement. Is there another patient-focused concept emerging?
Yes, the patient acceptable symptom state, or PASS. It's usually a single question. Is your current state acceptable to you? It's a threshold. Are you feeling well or satisfactory, regardless of how much you've changed? It complements change scores by asking about the absolute state achieved.
Interesting. A different way of looking at success. Okay, so we've collected the outcome data. Now we need to analyze it. Statistics. What are the basics we need to grasp?
First, know your data type. Is it continuous, like age or height? Or categorical, like yes, no, or mild, moderate, severe? That dictates the stats you can use. Then you use descriptive statistics to summarize your sample frequencies: mean, median, mode for the central point, standard deviation, or range for the spread. It gives you a picture of who was in the study.
And then for comparing groups or looking for relationships.
You choose inferential statistical tests based on your question and data type, comparing 2 group means, maybe a t-test, 3 or more groups. ANOVA, looking for an association, correlation, predicting an outcome, regression. The test must match the question.
When we get the results, the p-values, the confidence intervals, how do we interpret them beyond just p.05?
Right, the p-value just tells you the probability of seeing your result if there was truly no effect. Less than 0.05 usually means statistically significant, unlikely due to chance alone. But the confidence interval, the CI, is often more informative.
Why the CI?
It gives you a range of plausible values for the true effect in the population. A 95% CI means we're 95% confident the true value lies within that range. It tells you about the precision. Narrow CI means more precise estimate, wide CI means less precise, and crucially, you can compare the CI to the MCID. Does the entire range of the CI fall below the MCID, or does it comfortably cross it? That gives you a much better sense of clinical significance than the p-value alone.
The CI gives magnitude and precision, beyond the numbers, presenting data visually. Tufts principles.
Yes, Edward Tufts' ideas about graphical excellence and visual integrity are key. Show the data clearly, avoid clutter, chart junk, make sure the graphics accurately represent the numbers without distortion. Maximize the data-ink ratio, essentially.
And the Cleveland and McGill hierarchy. What's that telling us?
It's about how accurately we perceive different visual elements. We're best at judging position along a common scale, like bar charts. Less good with angles or areas, like pie charts, so it guides choices. Bar charts are often better than pie charts for comparing proportions because we judge length more accurately than angle or area.
Practical tips for figures and papers, then.
Make them stand alone. The legend should explain everything needed to understand the figure without going back to the text. Define abbreviations. Keep it clean. Focus on the data. Let the substance shine through, not fancy graphics.
Brilliant. Okay, we've looked deep into individual studies. But knowledge builds up over time. How do we handle multiple studies, different designs, the hierarchy of evidence?
Right. The hierarchy concept ranks study designs based on how well they protect against bias, especially when looking at cause and effect. RCTs are generally at the top for intervention questions because randomization minimizes bias. Below that, you have observational studies. Expert consensus often shapes these hierarchies and reporting guidelines like consort for RCTs.
RCTs are the gold standard for interventions, then.
Generally, yes. For asking, does treatment X work better than treatment Y?
But they have drawbacks, as we discussed.
They do. Not always possible or ethical. Strict criteria can limit generalizability, how well the results apply to typical patients. And the underpowering issue means we have to be careful interpreting no difference findings.
So observational studies have a key role, too. Cohorts, case controls.
Absolutely essential. When RCTs aren't feasible, they provide vital information, especially on prognosis, risk factors, real-world effectiveness. They often generate the hypotheses the RCTs then go on to test. They complement each other.
You mentioned case control studies are research in reverse.
Yes, that's a good way to think about it. You start with people who have the outcome, cases, and people who don't, controls, and then you look backwards in time to see if exposure to potential risk factors differed between the groups.
And case reports, or series. Lowest level of evidence, but still useful.
Level V, yes. Not great for proving cause and effect, but invaluable for reporting something new. A rare side effect, a novel surgical technique, an unusual presentation. They alert the community, spark ideas, generate hypotheses for better studies later on, often the very first signal of something important.
So a whole ecosystem of study designs. How do we bring all this disparate evidence together? Systematic reviews.
Exactly. That's the next level up, synthesizing primary studies.
What's the difference between a quick narrative review and a proper systematic review?
A narrative review is more like an expert summary. They pick key papers, give their perspective. It's useful, but can be subjective. A systematic review is a research project in itself. It uses explicit predefined methods to find all relevant studies on a specific question, assess their quality using tools like Cochrane's risk of bias or minors, and then synthesize the findings transparently. It aims to be objective and reproducible.
And a meta-analysis fits in where?
A meta-analysis is the statistical part you can sometimes do within a systematic review. If the included studies are similar enough in patients, interventions, outcomes, you can pool their numerical results together to get a single overall estimate of the effect. This pooled result is usually more precise than any individual study.
Often shown in those forest plots.
Yes, the forest plot is the classic way to visualize a meta-analysis. Each study gets a line showing its result and confidence interval, and a diamond at the bottom shows the pooled result. Lets you see the individual studies and the overall picture at a glance.
But what if the studies being pooled are really different? Heterogeneity.
Yes, that's a major issue. Heterogeneity means the studies aren't all measuring the same underlying effect. It could be due to differences in patients, clinical, study methods, methodological, or just more variation in results than you'd expect by chance. Statistical. We measure statistical heterogeneity with things like the I-squared statistic.
And if I-squared is high?
High heterogeneity means you have to be very cautious about pooling the results. The average might not mean much if the studies are too dissimilar. You might explore why they differ using subgroup analyses, but the source rightly warns against just chucking out studies to make heterogeneity go down that can introduce its own bias. It requires careful judgment.
Synthesis is complex, too. Okay, shifting gears slightly to practicalities. Multi-center trials needed for big numbers, but sound like a nightmare to run.
They are incredibly challenging, yes. The benefits are clear, bigger samples, more generalizable results, but the logistics, getting ethics approval from every single site. The source mentions the Jupiter trial experience, how delays can mount up. Central IRBs might help streamline that.
What else makes them tough?
Standardizing everything, making sure every site does the procedure the same way. measures outcomes identically, fills in the forms correctly. Communication is absolutely key, keeping everyone connected and motivated across different hospitals or even countries. Lessons from trials like PIVL highlight the need for constant contact, maybe face-to-face meetings. And agreeing on authorship early on is crucial when you have so many contributors.
A massive coordination effort. What about registries? How do they fit in?
Registries collect data on routine practice. They track outcomes for large numbers of patients undergoing certain procedures like joint replacements or ACL reconstructions in the real world. They're brilliant for long-term follow-up, spotting rare problems, and seeing how things work outside the controlled setting of an RCT. The Norwegian Knee Ligament Registry is a great example.
Do registries have weaknesses?
Data quality can vary. Completeness might depend on whether reporting is mandatory, local resources. And comparing outcomes between centers using registry data needs careful statistical adjustment because the patients might be very different. Case mix.
Finally, economic studies. Why the focus on cost-effectiveness now?
Because healthcare resources aren't infinite. Costs are rising. And there's a push toward value-based care, getting the best outcomes for the money spent. So we need to evaluate not just if a treatment works, but if it's worth the cost compared to alternatives. The value equation. Outcome divided by cost.
How do you approach that?
You need to measure both the costs, surgery, hospital stay, rehab, complications, and the outcomes, clinical scores, quality of life. But the crucial thing the source highlights is defining the perspective. Are you looking at costs to the patient, the hospital, the NHS or insurer, society as a whole?
Why does the perspective matter so much?
Because it changes what costs and benefits you include. A societal perspective includes lost productivity, which a hospital perspective wouldn't. The best or most cost-effective option can look very different depending on whose costs and benefits you count. The example in the source about different bone-cutting tools makes this really clear. The cheapest tool isn't necessarily the fastest or most accurate. You need clear criteria.
A really important nuance we've covered so much. From EBM origins, ethics, study design, outcomes, stats, synthesis, practicalities. How do researchers share all this work?
Dissemination is key. Usually through peer-reviewed publications, scientific papers, and presentations at conferences, like posters or talks.
Tips for writing a good paper.
Follow the standard IMRAD structure. Intro, methods, results, discussion. Avoid common pitfalls like trying to include absolutely everything, repeating yourself, or overstating your conclusions. Don't claim causation if your design doesn't support it. Outline first. Work with co-authors. Manage references properly. Create clear figures and legends. And discuss authorship early.
Abstracts and posters.
Abstracts are the concise pitch grab attention, convey the key message. Posters need to be visually clear, tell the story graphically, but have enough detail for someone to understand the basics, even if you're not standing right there. Good formatting, clear fonts, and always disclose conflicts of interest.
And presentations.
Tell a story. The discussion is vital. Interpret your findings, place them in context, acknowledge limitations, be ready for the Q&A.
Lastly, scientific meetings. More than just listening to talks.
Oh, much more. They're vital for learning, seeing unpublished work, refining your thinking, prepare beforehand, check the program, abstracts. But the networking, that's equally crucial.
Networking.
Yes. Connecting with peers, senior figures, potential mentors. Especially for junior people, the source emphasizes this. You build collaborations, get advice, find opportunities. That face-to-face interaction is still incredibly valuable, perhaps even more so in our digital age. Watching senior colleagues interact is also a great way to learn professional norms.
This has been incredibly comprehensive, a real journey.
It has, from how do we know, through ethics, design like randomization and blinding, measuring patient outcomes with PROMs and MCID, interpreting data, understanding different study types and synthesis, right up to the practicalities of multi-center trials, registries, and sharing the work.
And for you listening, as professionals in this area, grasping these principles isn't just academic. It's absolutely vital for critically evaluating the research that informs your practice every single day. It helps you make better, more informed decisions.
Knowing how the evidence is generated allows you to be a much more critical and insightful consumer. You can ask the right questions about a study's methods and understand the true clinical weight of its findings.
If this deep dive has been helpful, we'd really appreciate it if you could rate the show and perhaps share it with colleagues, maybe on LinkedIn or X, and to leave you with something to think about. We've seen the power of RCTs for controlling bias and the richness of registry data for real-world insights. How might linking these two worlds, combining large-scale registry data with embedded randomized comparisons, perhaps change how we understand treatment effectiveness across the diverse reality of orthopedic practice in the future?